Good afternoon, everyone, and thank you for joining us on this Facebook Live about childhood vaccinations. There have been changes on the federal level to the childhood vaccination schedule, and we are here today to discuss what that means for you and your family. Before I introduce our guests today, I want to remind everyone, if you have questions, put those questions in the chat of this live video, and we'll be able to get your questions and work them into our conversation. And if we don't get to your question during the conversation, we certainly can engage with you in the comments later on. We'll also be making more content about this topic over the next couple of weeks and months across all of our platforms here on Facebook, on YouTube, Instagram, TikTok. So be sure to follow us across all of our social platforms as we touch on this topic and other important topics that impact you and your family. So joining us today to kind of break down what these vaccination changes mean, you may recognize this familiar face, Dr. Marcy Dries, our Chief Infection Prevention Officer, Dr. Stephen Epps, Pediatric Infectious Disease Physician here at ChristianaCare, also the President of the Delaware Academy of Medicine and Public Health. Thank you for joining us today, Dr. Epps, and Dr. Jessica Fields, a maternal fetal medicine physician and co-director of labor and delivery here at ChristianaCare. Thank you all so much for being here with us today.
Thank you.
There could be a lot of people watching right now who have a general understanding. I heard things changed. I don't actually know what any of this means. So Dr. Dries, give us a general overview of these changes.
So the existing childhood vaccination schedule that has been published by CDC for many, many years basically had recommendations for 18-ish diseases that are recommended to be vaccinated against for all children. The new guidelines kind of took some of those and kept them for all children, but then they moved others to a at-risk category, and then yet others to what they're calling a shared clinical decision-making. So I think it's made it a little bit more confusing in terms of, who is supposed to get what and when, and they also decreased the number of doses that are recommended for some vaccines, but not all.
So Dr. Epps, they're calling this a 3-tiered framework. So I'm sure to the general parents, myself included, not entirely sure what that means. So how would you explain that to a parent?
Well, as Dr. Dries just said, that there are some that will not really be changed very much in the new schedule, which is good. So those will be for all children. And then there will be some that are recommended only for children who are at risk. For example, if you're missing a spleen, you would be recommended to get the meningitis vaccine. And then there are some that will be based on shared clinical decision-making, meaning that the parent, or in some cases the patient, has a sit-down discussion with the provider, the doctor, and makes a decision about whether they want to go forward with the vaccination based on their risk, their ability to tolerate risk, and other patient-specific factors.
So the shared clinical decision-making vaccines, flu, COVID, Dr. Fields, you're working with pregnant mothers all the time, having these conversations. Shared clinical decision-making for flu, how will that impact going forward? Should people now be waiting to get the flu shot? Should they not be getting the flu shot? How does that work?
That's a great question that you're asking here. So I like to emphasize too that parenthood really begins with pregnancy. And so you're right that while patients are pregnant, they are thinking about their future children and how pregnancy can impact them. So in general, for specifically like the flu vaccine, we're still recommending the flu vaccine to all of our patients. That is something that can be very beneficial and protect against flu, as those antibodies from mom can cross over to the baby as well and provide protection for young ones after they're born. Additionally, even extending to other vaccinations, we're still recommending our traditional Tdap vaccination in pregnancy, and that is something that's part of a recommendation that hasn't changed. So we are continuing to do that.
And I would just add, the term shared clinical decision-making has been part of the ACIP and CDC recommendations for many years, but the way it's being interpreted now is different. So the way it was intended to be used is when there truly is uncertainty as to whether a certain vaccine recommendation should apply to all people or all people within a certain age group, when there just wasn't enough data or the cost effectiveness maybe wasn't clear. That is when they recommended using that term, and they did it, judiciously, because they know it's difficult to implement, right? It's confusing for providers, it's confusing for parents and for patients. And so they really try not to use that term unless there really is some clinical uncertainty about some of these vaccines. And that the vaccines that are currently listed under shared clinical decision-making, there is not that clinical uncertainty. And in some cases, like the flu vaccine, for example, for many years, it was like, well, get a flu vaccine if you're below this age or above that age, or you have this, that, or the other, underlying condition. And it ended up covering like 75% of the US population. So at that point, it's just easier to say everyone should get it because it's so much less confusing, easier to implement. And the old table was really never, it was never a mandate. The CDC doesn't have that authority to mandate anything. It's really, it goes to the state level when you talk about school requirements or anything. They're the ones making the decisions about which of the vaccines on this table should we mandate for school entry. And they typically have chosen the ones that are dangerous and can be spread easily in a school environment. And so, I think the changes were meant, I've heard things like, oh, there's no longer a mandate. Well, I mean, it never was a mandate. So I think it's just made it more confusing in some cases that, Hep A now is for high risk. Well, who's at high risk? Well, anyone who eats fast food, theoretically. There's been lots of foodborne outbreaks, and not just fast food. It's been spinach, it's been random things. So theoretically, everyone is at risk for hepatitis A. So it's hard to interpret.
And
Well, I was going to say, up until a week ago, there are only two conditions that were under the shared clinical decision-making, which would be the meningococcal B vaccine and HPV vaccine for older young adults, if I can say that, 27 to 45 years of age. One of the dangers is that, and you alluded to this, people may interpret this as it's optional. And quite honestly, providers, doctors and other providers have had a little bit of trouble, I think, understanding what shared clinical decision-making is. And it's been shown that, using that or using a targeted vaccination approach, much lower rates than if something is universally recommended.
Dr. Dries, you mentioned hepatitis A. There's also changes to hepatitis B. So how are those conversations going, Dr. Fields?
Right. So I wanted to piggyback off of what you said as well about everything being confusing. So as I'm seeing patients in the office, I really want to stress to patients that we do want to talk to you about any of the questions that you have about these changes, given that everything is confusing and evolving. Specifically with hepatitis B, something important to note is that we do test all mothers for hepatitis B in the office when they are pregnant. And so if you are not immune to hepatitis B, during pregnancy is an excellent opportunity to get the hepatitis B vaccination, which is still recommended. It's a 2-part series and we can give it in pregnancy. So that can be helpful on one stand front. And on the other side, then we're talking about that shared clinical decision-making for the hepatitis B for neonates. And I think it's really important that patients who are concerned about any change to talk about it with us in our office. Our clinical bodies have not changed recommendations as of now. We're still using that same body of evidence and recommending that patients get the hepatitis B vaccine for their newborns after birth.
Yeah, and I think hepatitis B is a good example that, if a mother is known to be Hep B positive or unknown because they didn't get prenatal care, they weren't tested, then absolutely it's still in the recommendations to give their newborn that birth dose. But I think, it's been framed as it's only a sexually transmitted disease or vertical transmission from mom to baby, and it's not. Like hepatitis B is very contagious, much more so than hepatitis C or even HIV, and it can persist on surfaces for a week. So, and it's, really any bodily fluid can transmit hepatitis B. So yes, we test moms, but what if dad has hepatitis B and doesn't know it? Roughly half of the people living in the United States that right now don't know that they have chronic hepatitis B. So, and then, daycares or, childcare providers, there's lots of people out there living with hepatitis B that don't know it. And so that was really the point of vaccinating those babies kind of first thing, getting that dose started so that they're protected. Because the earlier you're exposed to hepatitis B virus, the more likely you are to have a chronic infection. If you're exposed as an adult, you get really sick, turn yellow, blah, 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 but you usually get over it because you have a mature immune system. That doesn't happen with newborns. And so now, again, it's recommended for those at risk, which is known Hep B or unknown status, but it's shared clinical decision-making for those that are known to be negative. Well, again, sometimes women are exposed after that test is done. Sometimes the test is wrong. Again, sometimes it's someone else in the family that has hepatitis B or someone else in contact with the baby. And so right now the recommendation is not to give that birth dose, but to wait at least 2 months. there's no safety benefit to that. It's just risk. So it doesn't make sense from a clinical standpoint why we would be putting our infants at risk.
And just in terms of historical perspective, before 1991, there were about 30,000 kids in the United States under 10 years of age who had chronic hepatitis B. And they, at this point, 35 years hence, many of them are developing cirrhosis, liver cancer, et cetera. It's a bad disease. And when the recommendation came out for immunizing routinely all infants, those rates have plummeted 99%. It doesn't get too much better than that in the vaccine world. And so all of those children have been protected since 1991, are going to live nice, long, healthy lives free of hepatitis B.
Yeah, I mean, we've been there before, right? So we're deliberately going back to a program that didn't work.
And in terms of delaying it till 2 months of age, that worries me. And I'll tell you why, because I lived through this. Back in 1991, when the recommendations originally came out, they said, give it either at birth during the birth hospitalization or as soon as possible at the pediatrician's office. Well, those who got the birth dose in the hospital were protected by and large. Those who had their dose deferred, many of them became infected, unfortunately.
Let's talk more about how these changes have worked in the past. So Dr. Dries, you were a liaison for ACIP during COVID.
Mhm.
You and I talked often about the COVID vaccine, about RSV, about flu, in that 2020 to 2023 time period when you were working with them. So talk about how vaccine changes typically occur. It doesn't seem like in the past it's been let's make all of these changes at one time.
Right. So yeah, as a liaison, I was not a voting member, but I was there representing my professional society, which was focused on healthcare personnel, vaccines. But I think, each and every one of these changes would have gone through what they call an evidence to recommendation framework, where they take all the data, both published and unpublished data. And this is usually the CDC scientists, often dozens of them work on even just one vaccine change. And they look at everything from what is the public health problem that we're trying to address? What are the risks and benefits and harms of the vaccine recommendation? What is what's the acceptability of the vaccine? What's the cost effectiveness? What's the equity? And, does making this change in recommendation make it more or less equitable for everyone to get? So there's this whole framework that they use, and that they would normally have to present it in chunks because it's so much. You can't present it even in one public meeting. So often it would take 12 to 18 months to get through all the work group meetings to decide what was going to be presented to the public ACIP meeting, where then it was voted upon. And so, something as simple as do we recommend one hepatitis A vaccine or two? That would have gone through this extensive review and making sure that all the data being presented meets the high quality data standards. And all of that has kind of gone out the window. They're not using, even when they did talk about the hepatitis B birth dose at the last ACIP meeting, the level of evidence that was presented was nowhere near what normally is presented. And then all of these other changes were just made, kind of without any review at all by scientists. And I read that they did ask CDC scientists to weigh in on these changes, and they went forward with the changes anyway. So
The American Medical Association, American Academy of Pediatrics, American College of Physicians have all spoken out about these changes, voiced concerns about these changes. As a parent, I have a 1-year-old and a 4-year-old. That's a lot of information that's coming out at one time. And I think a lot of parents watching and a lot of parents, just in our community right now are probably going to you, Dr. Fields, during appointments, or other pediatricians that you work with, Dr. Epps, saying, can I just do what I thought we were doing? Maybe, I know personally, I'm personally planning on just keeping my boys on the schedule we've already established. So what should parents keep in mind? We have some public comments coming in as well. How do I talk to my pediatrician about these changes?
Well, first of all, anybody who wants to get a vaccine for their children can still get it. And any provider who wants to recommend it can still recommend it. So that's important to know. So for the viewers here on Facebook Live, I think most of them probably reside in the northeastern United States. It's important to know that Delaware, where we're sitting right now, and some other states in the Northeast have formed a collaborative in which they are we're anticipating that we would be having some of these unilateral, non-evidence-based changes made in the vaccination schedule. And so if you're in one of those states, such as Delaware, you will, the recommendations haven't changed. And we will be following ACOG, the American College of Obstetricians and Gynecologists, AAP, the American Academy of Pediatrics. The recommendations that were out there will still be relevant, and that's what we'll be paying attention to.
Yeah, and I said before, the ACIP table has never been a mandate, right, for anyone that to have to get a vaccine. However, what it did mandate was insurance coverage. So if it was on the ACIP list of recommended vaccines, private insurance had to cover it, public insurance had to cover it. There's usually a separate vote as to which, whether the vaccines for children program will cover things. I'm getting over a virus myself. So I think that's where the confusion is. I think in the near term, they will still all be covered. What happens after that is unknown.
And I'd like to focus on communication with patients in the office too, if there are any questions. And we can go through more of this history on these diseases, why vaccinations work and are important. And then talking about what we can offer at different stages during pregnancy, and then again, postpartum. So I think it really comes down to having conversations surrounding these topics so that everyone understands our recommendations here at Christiana within Delaware. And everyone is talking about this issue at present.
We also just had a question come in. What sources should these parents be looking at? Certainly, we're grateful for everyone who's in this conversation. Jennifer's asking, what are those reliable sources that you would recommend pointing people to?
So I would turn to recommendations from the AAP, American Academy of Pediatrics, and the American College of Obstetrics and Gynecology for their recommendations. And then I think that turning again to healthcare providers, ask for resources so they can learn more about the different vaccinations. And there are many different resources that we can provide directly to our patients about vaccination and why they work and why they're important.
So that's a really good question. I think maybe the most important takeaway from today is pay attention to those science-based, evidence-derived recommendations that were really the way of doing things up until last Monday. And it should be noted that the AAP and ACOG and the Infectious Disease Society of America are among the over 200 organizations that are in opposition to these changes and that have written to every lawmaker on Capitol Hill to say, we want to stick with the old guidelines.
What about schools? I know there's probably a lot of parents thinking, will this impact all of the vaccines that I need to get my child to enroll in kindergarten in the fall, or whatever the case may be age-wise? Do you think this will eventually have an impact on schools? I know it's all still very up in the air, but people are asking.
It's a great question. And there's a disconnect currently, and I'll just give the example of Delaware because we're sitting in Delaware right now. Delaware requires 3 doses of the hepatitis B vaccine for school entry, and at least one dose of the meningococcal disease vaccine for middle schoolers and high schoolers. Well, right now, those are in the category, according to the recent changes, of shared clinical decision-making. Well, you can't have both. You can't have it required for school and have it, something that people can easily opt out of.
And you mentioned meningitis. I think meningitis is, if anyone has known anyone with it or knows how bad that can be, it seems to be, why wouldn't you get that vaccine? So Dr. Dries, what is your statement on that?
So, bacterial meningitis has a 10 to 15% mortality rate. And, and the survivors often have amputations, brain damage. It's a terrible, terrible disease. I think all of us who have ever treated a patient with it will never forget that patient. It's horrible to see a young, otherwise, and it, can kill someone within 24 hours. Like and it can cause outbreaks in college campuses and elsewhere. So why would you not want to prevent that disease? It just makes no sense to me.
And I'll editorialize by saying that the people who made these changes last week, who direct the various agencies in Health and Human Services, are not people who've ever seen cases of meningococcal meningitis or pertussis or measles and watched somebody suffer and die as a result of these vaccine preventable diseases.
And we're having this conversation in January where another headline is that flu is kind of everywhere. So Dr. Dries and Dr. Epps, we have often over the years put out the please get your flu shot, conversation. Right now, we're also talking about numbers on the rise. And that's another one where I'm sitting here thinking, what is the benefit of not getting your flu shot? So I think that there's a lot to argue there as well.
So, I mean, I think everyone is concerned, obviously, about side effects of vaccines, and that's, and it's a risk benefit discussion. The nothing in life is completely without risk, right? Walking across the street is not completely without risk.
Sure.
So there is, no one out here is saying like there's never been a side effect from any of these vaccines, and some of them have sometimes been serious. That is absolutely true. But when you look at the risk of flu, and 288 children died from flu last year, it's hard to say. Like now, it's if you want to get it, you can't. I mean, yet children under 4 particularly are at high risk of hospitalization and death from flu. So, and the flu vaccine has been proven over and over again to be extraordinarily safe. So I think it's two things. It's mom getting vaccinated during pregnancy to prevent the baby before they can get their own vaccine at 6 months, and then again, vaccinating those young ones.
So how will shared decision-making for things like flu and COVID and RSV impact those youngest toddlers who can't yet get it at Walgreens or things like that, or the ones that can? How does shared decision-making work at a pharmacy? Will you have to go to your pediatrician in order to get the flu shot?
So for children, I mean, so the way it impacts is, you're supposed to have the opportunity to have a conversation with at least a nurse, if not a provider. So it does, in practices that might have standing order protocols where, it's assumed that if the parent wants it, the MA can just go ahead and give the flu vaccine. That sort of protocol won't be available. So they'll have to have like an order for it. So, I mean, young children like that usually can't get vaccines at pharmacies anyway, due to state laws. So they will have to see their pediatrician or family practitioner anyway. And it should still be covered even under shared clinical decision-making. So I think, in the near term, that won't be a huge barrier, but, again, we do worry about the longer term, coverage, especially for those that they've decreased the number of doses and stuff like that.
And Jessica, I think there's a lot of pregnant women right now who are saying, I have enough to worry about. I don't also want to have to worry about what I should and should not be getting. I'm trying to follow my doctor's recommendations. What is your message to the pregnant women listening to this right now who just feel a little overwhelmed by all of it?
It definitely can be overwhelming because pregnancy is a difficult time. But I'd like to kind of flip that question and say, it can be even more difficult if you end up getting the flu, for example, in pregnancy. And so I would, recommend getting the flu vaccine, which is, again, everything's what are the benefits, what are the risks conversation, but the flu vaccine has been well studied in pregnancy in the past, and we have been giving the flu vaccine for many years. And overall, that benefit outweighs that risk. And we are seeing more and more patients come into our hospital with flu, and that can have devastating impacts on babies as well.
And this is proving to be at least a moderately severe flu year so far, and driven in large part by this so-called drifted strain of the influenza A H3N2, which is called subclade K. There is pretty good evidence from both the United States and elsewhere that the currently available vaccines provide at least some protection against this bad bug that's driving the wave of flu that we're seeing now. So it's not too late. Everybody should who's eligible, which is anybody greater than 6 months of age without a contraindication, should be getting the flu vaccine.
We have a great question from one of our viewers that I think is where we'll end. Can you explain why these vaccines help the overall health of our community?
Well, I can give you some numbers.
Absolutely, please.
All right. Well, from the year 1994 to 2003, it was estimated that vaccines for kids in the United States, that vaccines prevented over 500 million illnesses, over 30 million hospitalizations, and over 1 million childhood deaths. So long proven track record. So I think that speaks for itself.
Absolutely. Dr. Dries.
No, I mean, I think, vaccines are one of those things where it affects not only you, but the people around you. So You know, it may be that you have elderly grandparents that the children are going to be interacting with. May have older siblings. You may have a newborn that can't themselves get vaccinated for many of these things yet, but will be exposed to the daycare germs that the other kids are bringing home. So I think, you know, it is a societal benefit. If we can reduce the amount of diseases in general, then, you know, we're protecting those children that maybe can't be vaccinated themselves because they are, you know, immune compromised, or that they aren't going to react to the vaccines as well as someone who's healthy. We're protecting everyone. You know, we saw decreases in invasive pneumococcal disease in adults when we were only vaccinating children. So it is, you know, we're sharing all these germs, unfortunately. That's why, you know, I mean, Jessica and I didn't share our particular germs, but we both have them that are circulating. But you know, when we have vaccine preventable disease, you know, diseases that can be prevented, you know, it just doesn't make sense to me not to try to do that.
And while I have you, I have to ask, because we've talked about this so many times, all the germs that are around, give a quick reminder of how we can stop sharing germs with each other.
So washing hands, covering your cough, hand sanitizer, masking. We're obviously not masked here today. No, otherwise I normally would be.
But a good reminder for all of our parents and families, on top of the vaccination, is to just keep your hands clean and your coughs to yourself. I know with my toddler, we're working on coughing into our arms. It's always a journey. Thank you all so much for your time today, and thank you all for joining us for this live conversation. If you have additional comments or questions for any of our guests today, please continue to put those in the chat and we can chat with you there. We'll also be putting videos out across all of our platforms, so follow us here, follow us on Instagram, TikTok, YouTube, and we will see you all again soon. Take care.